Hello, welcome to the webinar. My name is Dr. Prashanth Muthukrishnan. Thank you for having me here. I'm being joined here by my primary research staff residents, Dr. Mariam Khan, Gautam Talluri, Slobodan Pilipovich, Pawan Suri. Thank you to my chair of medicine, Dr. Ramaswamy, CMO, CNO, nursing ICU attendings at NCB. Today I'll be talking about COVID-19 case series at NCB, as well as adding a little bit on integrative medicine approach to COVID-19. Focus points for this talk. Number one, demographic and laboratory patterns in the first batch of ventilated versus non-ventilated patients with COVID at NCB. VQ mismatch as a spectrum in COVID ventilated patients, shunt being one end of the spectrum and dead space being the other end. Logistics, biweekly trends in manpower versus patient census during the epidemic, first half of the epidemic. And lastly, but most importantly, it's time to fix the root cause, the substrate of this pandemic called chronic disease, and what can we do about it? And for that, I would like to refer you to Muthu Integrative, a YouTube page that I've been maintaining, also on SoundCloud. Okay, for this, let me get back to my residents. Slobodan will be starting the talk.
So this was a prospective observational case series that compared demographic, medical, and clinical parameters in intubated versus non-intubated COVID-positive patients who were admitted to North Central Bronx Hospital during the initial surge of the COVID pandemic in New York City. The study was conducted between March 16th and April 1st on 23 confirmed COVID patients. Of the 23 patients, 11 required intubation and by implication had a more severe disease course, versus 12 patients who did not require intubation. We hypothesized that the burden of comorbidities was greater in the patients who required intubation versus non-intubated patients. The dysregulation of the immune system associated with chronic disease and the decreased threshold decompensation being the likely mechanisms responsible. In our case series, the majority of the patients were African American and Hispanic, accounting for 82.6% of the sample. 2 were Caucasian, accounting for 8.7%, and 1 patient was Nepali and 1 from the Caribbean. This contrasts the JAMA New York City paper, where almost 40% of the patients were Caucasian. Of the non-ventilated patients, exactly 50% were male and 50% were female. However, of the ventilated patients, almost all, 91% were male. While there was a large discrepancy between the sexes of the intubated versus non-intubated patients in a population sample, distribution of the races between the intubated versus non-intubated patients was even. So to sum the slide out, the majority of the patients were non-Caucasian. The majority of the ventilated patients were male, and the distribution of ventilated versus non-ventilated patients was even when separated by race.
Great points by Slobodan. And much of the inspiration for the templates for what we are trying to present comes from all the major publications from China, Italy, Seattle, and Northwell. And we know that initially there was a concern as to whether COVID-19 is a racially dependent disease burden. But seems like Northwell looked at their own population, and NYCHHC we know caters to a totally different set of population, and that's why you see that the target population is racially skewed. So whites, 40% in the Northwell population, as against African Americans and Hispanics being majority here. Okay, and then now I will move on to Gautam Talluri.
In this slide, we are going to see the correlation between COVID-19 and chronic medical conditions. We can clearly see in most hospitalized patients at least one comorbidity. Out of all the comorbidities listed below, hypertension definitely stands out. 14 of our 23 patients were hypertensive, with few of the patients having even more than one comorbidity. Apart from this study, we have seen and read many articles showing strong correlation between hypertension and COVID-19. Even patients with coronary vascular disease, diabetes, and obesity also ended up having severe COVID infections. Surprisingly, increased COVID incidence was not seen in patients with HIV, cirrhosis, or transplant patients as many expected. We will talk about it more in the later part of the presentation. Coming to the next slide, Being a small study, not many smokers were included given the circumstances. The most significant part being that all patients who tested positive for COVID-19 ended up being negative for flu or respiratory viral panel. New York being the epicenter of the United States, we would expect viral exposure in all cases, but given the nature of the disease, with more than 70 to 80% of the population being asymptomatic, exposure was reported in only 3 out of our 23 patients. Imaging was significant with nearly 21 out of 23 patients showing positive results in the form of reticular obesities or reticulonodular infiltrates. Coming to the last point, 6 out of 23 patients developed AKI on CKD requiring hemodialysis. To be noted here that this hemodialysis was new onset hemodialysis. CKD may not have been a significant comorbidity compared to hypertension, as we discussed in the previous slide, but we saw many cases finally needing hemodialysis for short or long duration at the time of the discharge.
Again, great points by the residents. And you see that when you put peripheral arterial or vascular related diseases all together, you see the burden of disease association with COVID and such diseases, which is coronary artery disease, CKD, CVA all together. And as I will mention later during my talk in integrative medicine, metabolic syndrome has a direct association with all of the COVID or other pandemic-related morbidity that we are seeing here. Thanks to the excellent communication between all of our hospitals in NYC, HHC, we were able to get patients all over from Brooklyn and Queens as they needed it, because the least that we could do for these patients is have them not in the ER, but at least in an ICU bed, right? Moving on to laboratory data, although here you see that the ferritin level in non-ventilated patients seems to be almost similar to the ventilated patients, I noticed that one of these patients was a sickle cell patient with an end-stage renal disease that happened to have one value of 19,000 of ferritin that made the mean value higher, but otherwise ferritin levels were much lower in non-ventilated patients compared to ventilated patients. We had a few sudden cardiac deaths, and we've been still trying to figure out how to capture these people either with troponins or with EKGs much earlier than we could. And I have mentioned the N here in certain places because those patients, we had less than 10 samples. You see that the number of days to intubation was around 1.3 as a mean, and number of days on the vasopressors were about 3 for these patients. Moving on to the pulmonary status, we see that the Murray score, which is a calculation of how severely the lungs are involved with the ARDS, was again significantly higher than patients who were not ventilated. And these are all very much expected. Fever spikes is something that I want to talk about, because even now we are still having a lot of trouble and challenging times trying to figure out, are these fevers due to COVID, or are these from bacteremia or other potential bacterial infections? And for that, we've been working with Dr. Berger, Susan Berger, infectious disease in antibiotic stewardship, and with the pharmacists trying to use MRSA screening from the NARES to see if we can get rid of vancomycin as much as possible, at least renal toxic medications, and practicing basics of sepsis management, which is culturing ET tube trach samples ahead of time so that you don't start antibiotics without some sampling. We are now seeing outside hospital transfers all over from the city with vancomycin-resistant enterococcus, VREs, pouring from all over. And so we are trying to do our best to reduce the number of vancomycin and other empiric broad spectrum antibiotic prescriptions. At the same time, trying to balance the aggressiveness and conservativeness. So age-wise, 63 as a mean against 56 in ventilated versus non-ventilated patients. BMI was equal, around 32 to 33. And here we see a very hot topic, neutrophil lymphocyte ratio, right? Greater than 3:1 is something that's popping up recently in literature. And in our patients, you see the mean lymphocyte count percentage on the diff CBC diff was about 12% as against 18%. So more sicker patients had a lower lymphocyte percentage. And that's something that we need to pay attention to in the next few slides I'll be talking about. Again, in continuation with the same attempt towards antibiotic stewardship, we are still trying to find out what's the best way of using procalcitonin in these patients. In the ventilated patients, you see the mean value of 6 was possibly because we had 3 of these ventilated patients having bacteremia and could have contributed to the higher levels. So, and you know that ventilated patients are at risk for ventilator-associated bacterial pneumonias as well. Okay. So going on to that neutrophil to lymphocyte ratio, there has been significant number of publications, over 2,000 publications in the past 1 year or so about this ratio being not just useful in infections, but much more than infections, inflammatory, cancer, many diseases. And this actually brings forth the hypothesis that we were talking about, saying, what is the player between chronic disease and COVID or communicable diseases related mortality and even non-communicable disease mortality? And it seems to be immune dysregulation, and out of which only one of those evidences or manifestations is neutrophil to lymphocyte ratio, right? So kindly note down if you have any questions at this time. We will move on to our next topic and we'll get back to your questions soon. The next topic is VQ mismatch and dead space that we have been seeing in our patients with ARDS. You know that at one end of the spectrum, we have a lot of ventilation going on in a place where there is not much perfusion going on. For instance, we are concerned about pulmonary microthrombi that's a possibility in COVID-related ARDS, and other end of the spectrum where there's a lot of debris inside the alveolus because of mucus plugging and inflammatory exudates that's dropping the ventilation with respect to the perfusion. So one would be a dead space ventilation, right? When there is a lot of ventilation but no perfusion, and the other would be a shunt. And somewhere in between is VQ mismatch that's happening in different proportions in different parts of the lung. And here in our patients, we were able to use one modality called as end-tidal CO2. End-tidal CO2 is the amount of CO2 that is detected in the breath that is exhaled out of the ventilator, right? And using this end-tidal CO2, we are trying to identify how much of dead space is present in these patients. And for that, we have the end-tidal CO2 minus PCO2, or PCO2 minus end-tidal CO2, the gradient, which also gives us the dead space fraction, right? In our patients, you see that we had data for a few patients on end-tidal CO2 and PCO2 gradients. One of our patients had very high gradient, about 21, and in that particular patient, we noticed for instance, that although we did not have a D-dimer for him, we literally saw that it was hard to make his CRRT machine not clot. So there was a high chance possibly that he also had a D-dimer. But in general, we noticed that the minute ventilation, which is a product of respiratory rate and tidal volume, varied all over these patients, right? Ranging from as low as 7 liters per minute all the way to 15 liters per minute. So these patients are extremely unique in their presentation and their manifestations, that not one of these patients is actually very similar to the other. Tidal volumes, this is one of the most important things to note. Do you see that there is no tidal volume that says 500? We have really moved on. We are seeing much lower tidal volumes these days compared to last year, thanks to the motivation from the respiratory staff. And plateau pressures, a very interesting point that I would assume that when the compliance and the overall severity of the ARDS is higher, then even the amount of dead space ventilation would probably be higher. But we didn't get that sense, just from looking at the plateau pressures, for instance, was high in patient number 3, but he did not have a very high minute ventilation. Similarly, we see here in patient number 9 and 11, high plateau pressures would suggest a higher disease burden in terms of shunting and poor compliance, but they're not necessarily very high, not necessarily the highest of minute ventilations in this group. Still, 10 liters per minute is high enough. And you see that one of these patients, this patient number 10, had such a high D-dimer of 35,000. Okay, so that is that. And you see this, all the 4 parameters seem to have followed each other in a particular manner. Patient number 7, you see that not only did he have the entitled CO2 PCO2 gradient being high, but there seems to have been a possible reason alongside, which is his volume status. 3 liters on day number 2 and 11 liters. And one of the reasons was that we were finding it so hard to dialyze him consistently because of the fact that he had such high D-dimers possibly, and the fact that he would clot his catheter very often. We tried to use heparin, and such patients were also extremely hemodynamically fragile, and we could not get these patients on intermittent hemodialysis because it was still very early phases of the epidemic, and we did not have enough manpower for CRRT machines. And that's something that we really improved with time. Some of these patients, you see, patient number 1, number 2, had a much different compliance compared to the rest of the population. And you can also see some, indices of driving pressure, which is the difference between plateau pressure and peak. So you see how, variable these patients are when it comes to their entitled CO2 PCO2 gradient. And one extreme case of making use of this entitled CO2 gradient was when a patient was about to code, and we actually decided to use this as evidence enough to actually push half-dose TPA to see if that would actually benefit the patient from coding. And he seemed to have survived from that particular code. And so this has been documented many, many years ago by Gattinoni from Italy, saying that higher death space, poorer PF ratio, heavier lungs, more deaths. And so when they found that there was more recruitable lung, there was a higher chance that there was also more dead space ventilation. And you may notice that dead space actually is increased just by the fact that we have an ET tube in place. And one thing that we've been noticing is that since converting patients to tracheostomy, the amount of dead space ventilation also is a slightly lower, and that helps these patients come off of the ventilator also once we go through the tracheostomy. In this current COVID season, Italy has already documented that there is a need for personalized ventilator care because some patients are having more V than Q, and some patients are having more Q than V, just within the spectrum of VQ mismatch. You see how the areas in the picture shown there of perfusion do not necessarily match with the ventilation. And when it comes to D-dimer, we had available data for 2 vented patients, which were actually not high on admission. So it seems like they do not present with high D-dimers initially, but then worsen over time. And you see that average for 5 ventilated patients was around 3,000 to 7,000, slightly higher compared to non-vented patients. Moving on to next phase, manpower. You see, this was a graphical representation shown by Governor Cuomo, for instance, in one of his speeches, showing a typical bell-shaped curve or an inverted V shape in hospitalizations. And we also saw the same pattern in discharges, a little bit more in terms of admissions. Thanks to our administration, Mr. Hector Santana and Chief Nursing Officer Dr. Mara for these information. However, our manpower recruiting did not match this particular trend yet. At least as of April 30th, it did not match. But I would assume after that, the inverted V shape is probably starting, that the number of nursing staff members is going down, given that the peak of the epidemic is over. So, and you see that there are certain dips happening during, say, for example, 4th April to 6th April, 18th April to 28th April. Those are weekends. And I guess weekends are not different in COVID season. It's still hard to recruit nurses and staff members. And night shift was in general lower compared to morning. An average census, 44 was a typical number, March 15, whereas jumped up literally 3 times to 113, and then slowly came down to 95. The nursing ratio, with nursing patient ratio, you see about 1:2.5, 1:2.3, and almost 1:1.3 was how we went. So that's logistics data. Now I'm going to move into a very important topic, and I would like to see what you guys think about this, and I'll be really happy to get some feedback. And all of these is on the YouTube page as well, into Integrative. So the hypothesis that chronic disease is synonymous or leads to immune instability is what we're working on. Certain biological, demographic, phenotypic markers seem to underlie the natural selection of critical and non-critical COVID-19 patients. Disease complex, we know, has 3 items. Number 1, agent, host, and environment, right? And therefore, the difference between these different patients, asymptomatic or symptomatic or critically ill or dead patients, comes from the interaction between the agent, host, and the environment. And therefore, during this epidemic, we have definitely done a good job on trying to fix the agent or trying to figure out the agent and trying to work on the host, which is trying to stay away from the agent. And the environment seems to have automatically tried to make some changes itself. But then there is a little bit more work to be done on the host part of it. And we've also obtained IRB for this entire study, and they actually waived consent because it was more a non-interventional study. So what I'm trying to say is that there is a common raw material for all of the pandemics that we have been seeing. Right now, we have at least 5 to 6 pandemics that are going on. Number 1, we've known the cardiac disease, the heart disease pandemic that's been going on for the past 5 to 10 years. And that has become the new normal now because 1,772 patients die every single day from heart disease. And we've moved on. Similarly, cancer, flu every year has slowly started coming down, the number of deaths from flu because of the vaccination. And COVID is no different, right? That's the new kid on the block. What are the leading comorbidities? We know hypertension, diabetes, hyperlipidemia, all these systemic diseases, right? We think hypertension, we think of specializing diseases to certain organ systems. We think COPD is a problem of the lungs, right? And that's where we need to move towards our ancient wisdom. We have to stop decentralizing disease to organ systems, and we have to move to a systemic understanding of disease, of chronic disease. Flu compared to COVID is 10 to 40 times less lethal compared to COVID, at least as of 2020. Not only is there a relationship between comorbidities and COVID, but also in cancer, we know, and from data in London, we have, again, you see, bar number 8, hypertension is the top choice for cancer. And then number 11, COPD is the next top choice for cancer to capture people. Number 3, diabetes, obesity 4. And guess what? No one can eat just one comorbidities. If you have COPD, for instance, 29% of patients, 58% patients had also hypertension. Similarly, all these cancer patients, there is a higher likelihood that they have more than one disease. And that's something that we need to pay attention to, as I'll tell you very briefly. The flu epidemic has been happening alongside this, but much less lethal, but still lethal. 39 million cases, okay? 18 million medical visits, 400,000 hospitalizations, and 24,000 deaths, okay? And you see in this picture here to the right, that in 2017, you see how tall the epidemic was. The black line is the threshold for calling it as an epidemic, and this time, the number of pneumonias, And influenza-related mortality has reached about 8%, which is above epidemic threshold, but then later it picked up, skyrocketed because of the pneumonias from the COVID, not from influenza. Okay. Well, again, in flu as well, we know what are all the diseases that are associated with flu-related admissions and comorbidities, right? Cardiovascular, asthma, chronic lung disease, metabolic syndrome, obesity. There's a common pattern here, and that's what I want to talk about. However, you see that there is about 10 to 15% of COVID patients and 7% of flu patients in at least 2020 that did not have a known condition. What does that mean? That's where I come into integrative medicine. There are 6 stages for a disease. I'm not sure if you know about it. All forms of disease or imbalance start from the gut. We have known this for many centuries, but we have not understood it. Balance comes from the 5 natural forces that exist and function within our body, both anatomically as well as physiologically: air, space, fire, water, and earth. And they combine in combinations to form 3 different phenotypes within us. Number 1 is called VATA, V, which is called Vata, and the next is P, Pitta, and third is Kapha, air and space, fire and water, earth and water. Each of these have certain functions in the body, and their balance stays within the gut, and when they go out of balance, then they start in the gut, accumulate, aggravate, spread, deposit, and localize into other tissues, organ systems before they manifest as disease. So as physicians, we actually see disease in our patients only when they show up to stage 4, 5, and 6, because they are now localizing to symptoms, because they have postponed or not paid attention or respect to the initial stage of symptoms. And I'll tell you some of the examples of those symptoms that are part of stage 1, 2, and 3. Okay, for instance, I'm going to take my example. Each of us has different proportions of these 3 natural compounds. And I happen to be somebody who's predominantly Vata and Pitta. I'll tell you why. So, for instance, air and space functions in our gut and in our lungs and in our brain, for instance, in the form of movement, which is breathing, the peristalsis, moving our thoughts from one thought to another, moving our joints, and the cardiovascular system in the form of movement of blood and blood pressure and so on, right? And when everything is in balance, then you have clarity of thought, control of blood pressure, good bowel movements, and so on. Whereas when out of balance, you can imagine the nature of air and space: dry, cold, moving, right? So you will have symptoms such as dry, rough skin, sensitive digestion, very fluctuant digestion. You delay food for like a few hours during a busy day at work, you will have problems. But we don't pay attention to this, we move on, right? And this accumulates over time, eventually manifesting as disease. A perfect example would be IBS. Constipation, fatigue, tension, headaches, underweight, insomnia. Ask the sleep physicians. They see so many patients who come in for clinic visits with insomnia, and they'll have classic features of not just insomnia, but all of these other phenotypic characteristics. AFib, hypertension classically goes along with this, right? Because everything is very easily mobile and very, very fragile. How can you bring air and space back to balance? Well, trying to stick to schedules, routine, right? Limit unpredictability. Warm things, because the rule of opposites works here. If you are already too much air and space, which is dry and cold by nature, then you have to move towards things that are opposite to your body constitution, right? Yin and yang, same concepts. Warm foods, soupy liquids, grounded environment, right? Morning meditation, trying to limit rigorous exercise when you are already air and space. Avoid all addictive behaviors, and because these people are usually at risk for innovation, creativity, moving from one place to another. And Audrey Hepburn was apparently a classic phenotype of Vata. Steve Jobs classic example for a pitta predominant personality, right? He would, have things the way that he wanted to be, right? And when things are in balance, then such people are amazing physicians, for instance, and amazing leaders. Um, However, when a person is made of pitta, fire and water, they're already hot. They will not tolerate things that are more heating. So things such as spicy foods, not a great idea, right? And we have to respect our automatic body's intelligence that usually wants us to go towards things that are opposites. We have to pay attention to it. So I'll leave you guys to look into these things at your leisure. And these are always available on my YouTube page, and I'll share the PowerPoint with you guys. Yeah, simple examples for pitta, right? And flame, when goes out of balance, is what manifests as inflammation. So autoimmune disease, classic phenotypes would be pitta predominant. Similarly, all of my asthma patients, they have a combination of first vata and kapha, because kapha is full of earth and water, which is heavy, right? And metabolic syndrome and asthma or atopy allergy goes so well with each other. Sluggish metabolism and all these guys that they need is things that will stimulate them, right? Things that are more stimulating in terms of environment, like action, activity, moving about, things that are spicy, black pepper, things that are, and even adventurous things to watch, music that's, upbeat. So those are the things that in the environment that will affect your body constitution. And a part of Ayurvedic assessment also includes pulse exam that confirms all of these findings. In my clinic, one of the important questions that I ask my patients is, how does your poop look like? And we all know about this. The role of stool in microbiome is also being documented in sepsis population. And I have been actually working with the microbiome specialists at Montefiore to try to see if we can study microbiome in our COVID patients to see if there is a potential for compassionate use of fecal transplants in severe comorbid COVID disease or critically ill COVID disease. And this was one of the observational studies that I've been doing with my asthma patients in my clinic, and this has been published for this upcoming American Thoracic Society. And I'm starting to work on a survey monkey that you might get sometime soon, where I'm basically interviewing, you can pass it on to your patients and your other relatives and friends. I'm trying to interview patients and physicians and staff about their lifestyle, their body constitution, and whether they had COVID or not, and etc. Very similar to Indian Ayurvedic medicine is traditional Chinese medicine, Greek, Arabic, European functional medicine. No differences at all. Same 6 stages of disease, rule of opposites. Paying respect to the biological clock is the crux of this entire talk. And in fact, Nobel Prize has been given to 3 amazing physicians from 2017 for documenting the evidence behind ancient wisdom in the circadian rhythm, right? And alongside the European medicine, we have 2 amazing programs that I would like at least one of them, Dr. Falaise, to see if he can bring over to our Jacobi, which is called the Dean Ornish Lifestyle Program, which is an amazing cardiac rehab program that also includes CBT, psychotherapy, stress, addressing stress, and functional medicine. And Wall's protocol was done on patients with multiple sclerosis, in which and Dr. Walls from University of Iowa was a patient herself of multiple sclerosis. And here I'm referring you to this biological clock, and I would like you to see if you can look into that. This is for nutritionists. If you have any nutritionist friends, kindly pass this on to them. Nutrition should not be based on carbohydrates, proteins, fats. It should be much more personalized than that. It goes down to understanding your body constitution first, and then looking at what are the foods that are supposed to be pacifying or opposing to the nature of your body constitution. For instance, if you are already a lot of air and space, then things that are good for you are sweet, sour, and salty. If you are already a lot of fire, pungent and astringent things such as onion, garlic, spice things are not a great idea. And so is things watching things, or for example, watching adventure movies for people who are already having too much going on in their life, trying to manage 5-10 things at a time doesn't help them. And this is how lifestyle action, priority of action on choosing your actions is very important in controlling your balance and imbalance. We've seen this in rats very well, and also in human studies, where keeping an intact host circadian clock was followed by detoxification, appropriate detoxification, motility, and environmental sensing that led to good cell growth and DNA repair and metabolic homeostasis, as against an impaired host circadian rhythm like jet lag, shift work, or delaying times of eating just because you are so driven passionately to serve these patients and that they cannot wait 5 extra minutes. That leads to dysbiosis and loss of diurnal rhythmicity, leads to obesity, gluten intolerance, and many more imbalances that just accumulate over time. And unfortunately, the loss of health cannot be realized today. It will take some time, but then still health has to be practiced 1 hour at a time, every single day, almost very similar to practicing a musical instrument. And we know one of the giants in the field of epigenome medicine has given us a beautiful book called Biology of Belief, called Bruce Lipton, and I would like to refer you to. So health is really not a single modality. It comes with a package, right? Vitamin D alone is not going to give you the real deal of fixing heart disease. However, it could potentially add something to the entire package that can still possibly promote immune stability. So adding yoga, adding vitamin D, or exposing to more sunlight, definitely. But it's not just medicines. It's not just herbal supplements. It's not just about moving. It's the entire package. And that's where I come into this particular cycle. This is the crux of the entire talk. Move, digest, and rest. If you keep cycling between these 3 actions, you are highly likely to create a balance between your natural forces. And that's where we need to focus on during these next few weeks as we go towards the second phase of this, or the downward phase of this epidemic. We all of us, during these troubled times, when there is such high workload, we're trying to balance between our ego, our passion towards achieving amazing patient care, and duty towards our home, towards our family, and duty towards our own self-health. And it's important that we try to balance these 3, and then alone can we sustain health ourselves, because we have to be examples ourselves, be the change so that our patients can follow these. Single tasking is something that I've always believed in, because if you are amazing at single tasking, then you will definitely be great at multitasking too. Single tasking, in other words, is called as mindfulness. Try to do one thing at a time. That's when you will feel grounded. Respecting the biological clock, as I said, because pharmacy seems to be driving much of the curriculum these days in medical schools and residence and even fellowships. It's all about clinical trials. We need to spend some time understanding the root cause of disease so that we can actually give the right education to patients, because I think knowledge is the most important thing that patients need from us, right? Lifestyle and nutrition and diet and so on. So as physicians, we have to be very careful to make sure how we prioritize self-help. Similarly, guide our patients also to choose how to prioritize self-help first, and that's the order of preference. Self-help, duty towards your home, duty towards your nation and society, and then eventually comes passion, desires, and addictions and inhibitions. And people who need to move have to move enough. People who need to rest have to rest enough. And that's where the clash comes, when people who need to move are resting more and people who need to rest are moving more. If you try to balance these things, you can strike health. So taking care of oneself is one of the most selfless acts of mankind, and try to see if you can balance more towards duty than desires. So I thank you all for your attention. So I'll go for the take-home points. We looked at manpower, patient flow at NCB, spectrum of VQ mismatch, and I would like to encourage all of you to see if you can start using Entitled CO2 in your own places to see if it's helpful. Demographic and laboratory features of NCB patients with COVID we saw, and chronic disease in the pandemics. It's just been the old story, but a new face. Move, digest, rest, single tasking, and I defer you to Integrative. I want to thank the pillars of NCB, women in medicine. Interestingly, we see that CEO Mrs. Contreras, CMO Dr. Anyago, Chair of Medicine Ramasamy, medicine attendings, ICU Dr. Nalamari, Stokal Pradhan, Dr. Mara. So many women in medicine at NCB have literally helped us have an amazing journey during this COVID pandemic. And I thank all of them for this wonderful support. Thank you for all the men in medicine, such as Steve from respiratory department, surgeons and anesthesia, amazing help, environmental services, cleaning assistants, the prone team, amazing, the Navy, the PT, OT, all of you, you've done an amazing job. Thank you for what you're doing. Thank you for my residents for being what they are. And thank you for this opportunity to answer some questions.